So we immediately proceed to the cadaver dissection of the nose, the ultrasound correlation, and the injection, mid-face and nose. And do we have the commentator here, Dr. Kwang Cheng Chang? Is he here by chance? Let's hope that he will join us. Anyways, we are ready to start. This is mine, so have a seat here. Okay, good. So we start with anatomical dissection, right? This is the program. Let me see, let me check. So if it's just 0, 0, 0, 0, 0, 0. This is, no, this is not this.
From the hospital. You can pronounce that
from the presentation. Okay, so can we start with the patient injection? Dr. Duang Nam Sawang. Hi, can you see us? Can you hear us? We can see you, but we cannot hear you.
Can you hear me?
Okay, now we can hear you. You can start, please.
Okay. I'm Dr. Duong Dao from Summit Clinic, Bangkok, Thailand. Today, I want to assess the patient with mid-face problem and periorbital. This case is female, 52 years old. They came here to want to correct periorbital and mid-face. In this case, I will assess in 4 categories. The first one, I will find the loss. Where is the loss to find the place to inject? First of all, we find the group. The first group that I see is a tear trough deformity. And the second group is a PMG Palvo-Mala group that is related to the tear trough ligament and ORL. And next group is a mixed sheet group. It's related to the zygomedical cutaneous ligament. And I found that there's some loss at the mid-face here. The next category is I will find where is the access. The access in this patient is the intraorbital herniation of the fat here, and some access of the skin a little bit. In the next category, I will find about the quality of the skin. By inspect, I see the permanent wrinkle here. If I test by pushing snap test, the elasticity is not good. And pinch head to check the thickness of the skin. I think she has not thin skin, not much thin skin. And the last, I test with the push test. The push test will be see that if the push test positive, mean it's a volume loss. But if I put test negative, it means that it's a tetheling form, the tear trough deformity. So in this case, I would collect the mid-face with the filler medium G prime, and we will collect superficially with the soft filler in subdermal area.
Okay, so we move to my case that is related to the one of the indication of the mid-face area. So in this case, I will be assessed about the nose job. So for this lady is a young lady, 24 years old. So can you zoom in, take a look at closer to the nose. So actually for the nose, the ideal nose is, can you take a look closer? Can you zoom in? Okay, so normally, well, the ideal nose shape for the girl, both girl and man, is about the straight dorsum of the nose. So, and after that, we have 2 angles that is related So by the front view, you can see the hollowness here and also the hollowness here. So actually, this case is had a flat nose and nice ideal shape of the
we have
nose.
okay. No, it's
Need
better.
to make a straight shape. Okay, we have to make a straight shape of the dorsum of the nose. And for the angle that related to the nose, we have two angles. So take a look when move the patient to the profile view. So the first one we call it nasolabial angle. So normally,
Can the
you
camera, please,
the
camera
profile view?
profile? We're looking for profile, not
Yes.
anterior.
Yeah.
The camera, please.
Yeah, this camera. Can you change to this camera?
Okay, thank you. Yeah, it's
Here.
okay now.
Okay. Take a look here. So so normally we have the first one, the nasolabial angle. So for the lady, it's approximately about 95 degree to 110 degree. And for this case, it's just a little bit narrow of this angle. So I'm gonna be inject to increase this angle by inject to the dorsal nasal septum here. And we can elevate the tip of the nose like this. So you're gonna be see the angle will be increasing. So sorry, here, increasing when the tip is higher. So stay for the lateral. And another angle ขอกล้องนี้ครับ Yeah, and another angle, the nose is related to the forehead too. We call it frontonasal angle. So normally it's around 110 to 130 degree. So some, especially for the Asian people, mostly have a flat of the dorsum of the nose has not proper angle here. So if you can elevate it, the dorsum of the nose, you can make a nice or perfect angle. So the anatomy is related, that related to the nose is from skin, subcutaneous layer, muscular layer, and a little bit space of the defect. And after that, to the bony structure and the cartilage structure.
Okay, Vachira,
So
thank you very
take
much.
a look
Because
to the page.
Vachira, can you hear me?
Okay,
We
fine.
need to go to the ultrasound, but
Yeah,
because
yeah,
we
yeah,
have
yeah.
two injectors,
Okay.
what I would be suggesting that Duangao, you can please treat the one side of the mid face of the patient offline, and then when we'll get online, we will see the other side and we will be able to compare. You don't inject the nose because we have only one nose. And we go to the ultrasound, please, Maurizio.
Good.
Okay.
Welcome, everyone, and thank you for letting me make this demonstration. I am working here with a device which is very different than others because it is adaptable to your finger. So you can actually work, see, and inject at the same time. And you can be experienced, you can know your anatomy, you can be skilled, but at the end of the day, it comes to what is below the skin of your patient. So using ultrasound will give you the opportunity to have this information and avoid problems. Now, when it comes to the mid-face, I'm going to teach you 3 important probe positions with this curved finger probe. Again, this adapts to the facial areas. It's a small little curved probe. And I'm gonna have a look at the mid-face. First, going medial to lateral, starting with the deep piriform space. We know we inject here to stabilize the mid-face, and I put the probe just really perpendicular to this space. And the deeper from space, I'm gonna stop the image. I'm going to go a little bit back in time. And this is the bone. Bone looks white on the screen. We know that everything that contains, can we maybe have the ultrasound camera? It's bigger, you see it there. Everything that is white on the screen, hyperechoic, it's dense. This happens with teeth, with bone, and so on. Then we have at the level of the deep piriform space, the deep fat, which is this layer here, right? And we want to do a perpendicular injection. If you imagine this is my midline, so my injection will go exactly there. What do I want to know here? First, the location of my angular artery. The angular artery is a danger zone. And in fact, this belongs to the nasolabial fold, the deep piriform space or this area, and we know that this is top 5 when it comes to filler-related blindness. So you want to know the location. If I want to know the location of this artery, I change to my color Doppler mode, and I have a look. So I really am very, very cautious. I do my vascular mapping very softly, and you will start to see a pulsating structure. This is an artery. It has a pulsatile character, right? And I go a little bit more towards the deep piriform space, which is that concavity that you see there. And if you do a proper vascular mapping and you don't see any artery on the periosteum, you will be more safe. In patients, when you have, for example, very thin patients that lack deep fat, sometimes this artery runs there, so you will be very thankful to know this information and change your injection strategy. Maybe using a cannula, maybe coming from another angle, and so on. So it's information that you get from your patient, and it's unique anatomy. It's not the cadaver, it's not the book, it's real life, it's your patient's anatomy. And here, for example, I just saw my angular artery is not in that area. So I am more aware that I am going to be safer with my injection. And another point regarding this injection area is the following. Have a look. The deep piriform space is this area, right? Here is my deepest area, and if I stop the image, this deep fat extends upwards at the level where the LLSAN muscle inserts. What is actually the important information here? Can you please do this aggressive look? There you go. Stop. And again. And stop. So muscles are dynamic. Can you do the move again, very soft? And stop. So there you go. I go back in time. This is the deep fat, this is the bone, and this hypoechoic, almost anechoic looking structure is a muscle. It pulls up the upper lip when you do this aggressive look, right? And the filler, once you inject it, it will spread upwards below the LSAN. So if you repeat these injections over and over again, when your patient smiles, that person will get this weird sausage in this area when they smile. So that's nothing appealing, right? So the filler will spread immediately into that area. We know about this from ultrasound studies. That as
Maurizio, we
Yeah.
know about it because we see so many people with it.
we saw many people
Many
with that,
people
but we
with it.
explain where does this
So
come
it's a
from? I
great
didn't inject the
explanation.
ear
Thank you.
trough, right? But it comes from those injections at the level of the deep piriform space, right? So, and that's why we see an improvement of the tear trough when we inject the deep piriform space. Now, moving on to the anterior cheek, I want to know here the following information. Do you see this little gap between the bone lines? The bone is this one here and this other layer here. And if you have a look at this gap, that's the infraorbital foramen, where the infraorbital structures will be located. And with that, I mean the artery, I mean the vein, and the nerve. And
Maurizio, could I interrupt you just for a second?
For sure.
I think it's very important for the audience to see how you're applying the ultrasound transducer. So at
Exactly.
the moment, you're in a sort of horizontal position, I can see, correct?
Exactly.
And I
So
think this is very important for beginners because how you apply that transducer is often forgotten during demonstrations, and you're
Sure.
demonstrating it beautifully.
when I do my entry point with my cannula, I usually use my finger probe on my left hand because that's my non-injecting hand. I inject with my right, but here for the demonstration, I'm using my right hand. So I pull the tissue up, I insert my injection instrument, and then I have a look with the probe. Am I on the bone? Am I in the fascia or somewhere else? Am I close to the infraorbital vessels? All that information is what you want to gain out of this injection. And if you have a look at this position here, so I, again, go in, have a look, after I inserted my injection instrument and I reassure myself where am I placing. I want to see my needle in this level or cannula. So on top of the bone at the level of the deep fat, what we call here the deep fat of the in this area, the deep fat.
So, Maurizio,
Yeah.
just to let the audience understand, because only 2 of them actually use ultrasound, as
Yeah.
we voted for that before. So
Yeah.
this is the only device, ultrasound device, with which you can inject and see the ultrasound picture
Exactly.
by manually. You don't need another assistant, right? So this is the difference between, because basically you had to inject here.
Exactly. So you're having visualization right away while you are injecting without changing your workflow, without actually taking more time to do your treatment because you're having it right on your finger and it's not heavy. It doesn't overheat. It's just 15 grams. So when I am here in the under eye area, let me just demonstrate to you the color Doppler here for the infraorbital vessels. And it is important to have this information because, again, you don't want to mess up with those little vessels that might get occluded, or you have maybe a little spasm and have vascular adverse event. So you see here at the right side of the image a pulsating structure. So that's an artery. It has a pulsatile character. And when I do the injection again in this area, I just go back a little bit in time. Okay, now I'm going to show this again for you. Here you go. You see the gap. You go a little bit closer. You see the vessels. So I want to keep my injection instrument away from it because the problem is when you overdo injections here, the filler is going to accumulate around that foramina. We have many different foraminas around the face, periorbitally especially, and that can cause pressure. Overaccumulation causes malar edema because the venous outflow is compromised here, right? So that was the second position. And the third position concerning the midface is the following. I'm going to try to keep this brief and very simple. I'm going to go back into the black and white mode, get a little bit of gel. When we inject the lateral cheeks, who is injecting here the lateral cheeks? The so famous CK1 point in order to contour the cheeks. All right, good to see. So when you inject material here, you will have the following thing. The filler is going to move to spread up to the caudal temple and also downwards to the preauricular zone. And I mean with that the deep preauricular fat. We just got an acceptance for our publication about this matter. And let me guide you through the following thing. I'm going to stop the image, go back in time, and I will walk you through the anatomy of this matter. So here is the bone. Here is the deep fat of the zygomatic arch. I am placing my probe. If you see how I am doing it on the model, I am really going from the lateral cheek downwards. Here is the temple. So these two anatomical units are connected with each other. And you see it here actually very clear. This is the zygomatic bone. This is here the temporalis muscle. And this is the temporalis, the temporal bone. So your filler will slip actually at the level of the intermediate temporal fat pad. Let me show you this. Roya just demonstrated this very nicely. And here is the intermediate temporal fat pad on your right, that hypoechoic, almost anechoic looking area. Here is the zygomatic arch, the bone, and when you place the filler here, it will slip here in this area, right? So you are also filling the temple. If you overdo this, you will overfill the face. This is actually one of the areas that belong to the overfilled face complex of the midface. And if I go downwards, now at the level of the, on your left is this white line is the zygomatic arch. It's a very short line. And if I go downwards, I'm going to change my scan direction. So your left side of the image is the zygomatic arch. Here, the zygomatic arch is right in the middle. is this white line in the middle. On your left is the superficial temporal fat pad or the intermediate temporal fat pad. And if I move downwards to the mid-face, then I will find the following thing. Can you please clench your teeth? There you go, and stop. Good. I'm going to go back in time. This is the zygomatic arch. And if you place material here, it will end up at the level of where the masseter and the parotid actually are located. So that's the deep preauricular fat. I will show you the following thing. This is the masseter. This is the mandibular bone, the ramus of the mandibula. This is the zygomatic arch. Here you have this space that expands here, and this is the level where the parotid gland starts. Sometimes you have an accessory parotid lobe, and the filler is going to end up exactly in this level. That's the deep preauricular fat.
So Maurizio, I think it's very much, they dedicated 5 minutes like for ultrasound, so it was a little bit. Benrita, are you ready for the anatomical dissection? Again, we have 10 minutes for both the nose and the mid-face. So please share with us the most important anatomical structures. Thank you.
First, we can divide the mid-face into the medial and the lateral part by using the line of ligament. The line of ligament is the lateral orbital thickening zygomatic retaining ligament and the mandibular retaining ligament. You can easily divide the mandibular retaining ligament from the surface. If you see the pre-jaw cut here, this is represent the posterior end of the mandibular retaining ligament. So here I cut along with the line of ligament and would like to show you the medial mid-face first. So the medial mid-face, here you can see the area under the eye that we call some infraorbital area. You can easily identify the surface by you can see some nasojugal groove and some tear trough here, and nasojugal groove can continue to the mid-cheek groove here, but the tear trough can continue to the palpebromalar groove here. So below this groove, we can define as the medial mid-face, or you can see the nasolabial fold related in this area. After that, I would like to show you the layer by layer dissection of the infraorbital and the cheek area here. The first layer, as you can see here, this is the skin layer. The skin, under the skin, you can see the superficial subcutaneous fat or superficial fat compartment. At the nasolabial fold, you can see the superficial nasolabial fat compartment. And you can again see the triangular shape of the fat compartment here. This is the superficial medial cheek fat compartment. Below, inferior end of the nasolabial fat compartment, you can see the upper jaw compartment here. So, and then I will remove the fat. The layer number 3 that you can see here, this is the area of the infraorbital area. The infraorbital area here, you can see the muscle layer or the orbicularis oculi muscle layer here. It have the palpebral part and also have the orbital part here. I have to remove the muscle. Can you see here? Under the muscle, you can see at the medial part here or the tear trough area here, you can see the bone here. Because, could you please zoom in? Because as this area don't have a lot of the fat, deep fat here. So when you do injection here, you must aware that it don't have a lot of fat to make like the gliding pain for your product here. But laterally, you can see the thick fat compartment here. That's we call the SUV or the suborbicularis oculi fat. This area separate from the orbital content by the tear trough ligament that attach the orbicularis oculi muscle to the orbital rim here. But laterally, the tear trough ligament continue to the orbital retaining ligament here. It have the thicker band of the ligament when compared to the tear trough ligament here. Below the SUV or the infraorbital area, you can see the ligament that's defined as the lower boundary of the tear trough and SUV. That is the zygomatic cutaneous retaining ligament. And you can see the ligament attachment here. So the ligament, when you do injection of product at this area, the the product will be located only in this area, cannot migrate into the mid-cheek because it has the ligament as the boundary here. So below the ligament, below the tooth, you can see, sometimes in the cadaver may not see prominent of the malar septum, but normally we can see the malar septum is a thin septum that separate the tooth and the periorbital fat, and below this area is contained the area of the pre-zygomatic space that contain the periorbital fat, and then we can see the bone under here. So right now we are moved to the medial midface area, and can you see here the skin, the subcutaneous fat, and can you see here at the level of the orbicularis oculi, you can see some fat located above the levator labii superioris muscle. Here this is the deep nasolabial fat compartment that located at the premaxillary space here. And lateral to this muscle, you can see the zygomnicate minor muscle and zygomnicate levator labii superioris muscle. Levator labii superior aliquid nasi muscle, and laterally you can see the zygomnicate major muscle here. Under the zygomnicate major muscle, you can see the septum that we call the transverse facial septum. This is the reason why when you do injection in the deep vein here, it's separate from the buccal area, because this have the transverse facial septum behind the zygomnicate major muscle, and deep to the levator muscle, you can see the group of the fat compartment here. This is a deep fat compartment, consists of the deep piriform fat close to the piriform aperture, and we can see the deep medial cheek fat and deep lateral cheek fat close to the zygomnicate major muscle here. And inside the deep medial cheek fat, you can see the bundle of the infraorbital neurovascular bundle here. So this is very important when you do injection from the inferior part or medial part of the face and then go to the teardrop area. You must insert the cannula into this foramen. So, and you can see the facial artery run deep and then under the muscle, and then it's become more superficial at the lateral part of the nasal area here. So right now we are moving to the lateral face. Lateral face have the lining layer in the different when compared to the medial face, because the lateral face have the parallel layer. The first layer is the skin layer, and you see here, and this is the second layer. The second layer, you can see the superficial, middle, and the lateral cheek fat compartment here. And after I remove the fat, you can see the third layer here. This is the smart layer, connect from the platysma to the superficial temporal fascia at the temple. So under the smart, you can see a lot of the important structure, especially this is the facial nerve branch of the facial nerve branch exit from the anterior part of the parotid gland. So please aware when you do injection in this area, you must insert the cannula into the parotid gland. So if you, in this area, you may get the infection. And we also have the facial nerve branch, that zygomatic branch here, buccal branch here. And we have very important structure, is quite big here. This is the parotid duct here, the parotid duct. And we also have at the inferior border of the mandible and the anterior border of the masseter muscle, we can see the facial nerve, facial artery here. So this is the overall layer of the lateral face. So the recommendation maybe you just make sure that you inject not too deep. So next we are going to the last area is the nose. Move to the nose. As the nose area, you can see the layer of the nose. So sorry, can we a little bit move the camera and then do like this, please? Okay.
Yeah.
Can you hold the head?
Benita, please give us
Hold.
very short introduction of
Yeah,
the anatomy
okay.
of the nose because of the restraints of the time we don't
Yeah.
have.
So the first is the skin layer, and you can see the second layer, we have the fatty layer, and you can see some vessel inside the fat layer. So this is why you inject in this layer is very dangerous. a lot of vascular here. The vascular that support the node is dorsal-nasal artery come from the ophthalmic artery. So if I remove the fat layer, you can see once again above the third or the smash layer, muscular layer, we have the connection between the dorsal nasal and the lateral nasal artery and the columnar artery at the tip of the nose. And below the fascia or the muscle and the vascular here, you can see the nasal bone and the cartilage, alar cartilage, and the lateral part of the septal cartilage here. And sometimes we will have some periosteal band at the nose also. So it's quite dangerous when you do injection at the nose. That's all about the anatomy of the midface and the nose.
So Benrita, just to summarize for the audience here. So when we are talking about the nose, there is no such a thing as the safe area, right? The artery is deep and superficial, and this is one of the reasons.
Yes, in this cadaver, as you see here, we have some deep branch of the dorsal nasal artery. Fortunately, sometimes this branch runs paramedian. So when you do injection in the real patient, you must close to the midline.
Yeah. So midline and the prey. This is the recipe. So now we must switch to the live injectors again. We have two injections, the midface and the nose. And I asked the midface injector to prepare one side so we can really see currently the result. And then she will demonstrate the other side. Okay? Can we switch to the, okay, we are there. Can you hear us?
Okay. อันนี้เดี๋ยวตั้งมุมเดียวกับคนไข้ให้หน่อยค่ะ ตั้งหัว เดี๋ยวเผื่อเขาเรียกให้ใส่เข็ม
We see you and we hear you. So tell us few words about the product that you are using first.
Oh yeah, I use a medium G-pram. First at the medial SUF and lateral SUF, 0.5 cc here and here. Yes.
So this is the side that you already injected, right?
So this is the side that you already injected, right? Oh yeah, this one. This side.
So this is the side that you already injected, right? Is it correct?
This side. This side. I already correct this side.
Yes, she did.
First, I inject at the SUF, medial and lateral SUF, 0.5 cc, and use the soft filler to collect the superficial at the tear trough, and palpebral groove, 0.5 cc.
Can you start, please? Can you hear me? Please do start injecting the other side because the audience wants to see your technique, injection technique, please.
Oh, yeah. Okay, I start now.
Thank you.
We start first with medium G-pram. Use 25 G. The layer is in the SUF area, under the OO muscle. My tip is here. My tip of the needle is here.
Yeah, you can make comments.
We inject filling the medial SUF. First, and
your purpose here is volumization or correction of the titular deformity?
Volumizing in the SUF area, in the deep. So I will collect the tear trough after by the soft filler. Here is my tip is in the lateral SUF.
So you want to inject into the prezygomal space or into the SUF?
Yes, into the SUF.
Into the SUF.
Because I use a medium G-pram. Yes.
Could I ask Mauricio at this point, just what are the dangers of this trajectory? Can you be on top of the orbicularis very easily, or not with this
You
trajectory?
can not only be on top of the orbicularis, but also transpass the septum and also end up actually
Post-septum.
intraorbital, so
Okay.
post-septal.
So,
Yeah.
so that's one of the things that one has to be very careful of here with this technique, and you can see that the orbicularis rotating ligament is being
It's been
pushed.
transpassed, yeah. Mhm.
And I think that one has, for novice injectors, you have to be very careful that you aren't ending up superficially and injecting too much superficially or even intraorbitally. I think that's fair to say.
Yes.
I have a very funny question. What happens if we inject a bit of HA intraorbitally using cannula? Is there any specific danger? Because if you inject too superficially, it's visible, right? It's not dangerous, but cosmetically unacceptable. If we inject intraorbitally with the cannula, so except of losing the effect, because this is what happens, right, if you inject, are any specific dangers?
Well, I can answer that because it's reported that there are, and one radiologist in Australia has some cases, Moban Master,
Yes.
where there is chronic edema, and you actually have to go intraorbitally under ultrasound control to dissolve it. So it's quite a challenge. So it can be dangerous.
Edema, you mean soft tissue edema?
Yes, soft tissue edema. I mean, the layers are very intimate there. They're very, very soft. Is
Persistent
that fair
edema.
to say?
Yes,
So again, cosmetic, suboptimal cosmetic outcome, right? Because I want these people to understand when we are really endangering the patient, like injecting in the nose, versus delivering suboptimal outcomes.
You know, this is a very fine line, and the point is, be very conservative when you're doing this technique, because it's not difficult to get into the wrong space. And if we're looking right now, you can see the end of the cannula is actually subdermal, I think.
Yes, it's very superficial right now.
Yeah, so, you know, that's okay if that's where you want it to be, but you should be injecting very, very small amounts, I'm sure you would agree.
And the filler is not supposed to be intraorbital, right? We are not actually aiming for that, even if the patient might go away with that without problems, but that's not the point.
There are some cases in Taiwan, and some doctor intraorbital injection, massive hyaluronic acid, and make the patient diplopia. Diplopia, and some doctor inject the sculpture biostimulator into and the hyaluronic acid make diplopia is temporary. However, the biostimulator into intraorbital cavity permanent.
The point here is it's a beautiful field, our field. We create beautiful results, as we can see that the injector has created here, but we also don't want to create a misery. When something goes wrong, it's a heartbreak situation for everybody concerned, including the patient and the practitioner. So be very, very careful, be very conservative in your approach, especially in this area.
Yeah.
We've been scanning one day before all the day patients from here, and we got to the conclusion that they have much thicker subcutaneous tissue than the Caucasian European patients where we actually also work. Or, I mean, you're in Australia, in Israel, so, and that's actually a good thing for the people here because they can cope with the filler easier than a patient of mine. So when a patient comes to me asking for tear trough injection, like 9 out of 10, I say no.
Yeah, but you know, it's not only the ethnicity. You just keep in mind that we are treating young patients and elder patients, right? So young patients, they have thicker tissues of the elder patients, so it does not matter whether it's Taiwan, South America, Israel, Australia. It's age-related. Keep it in mind. We're teaching anatomy, we're showing you cadavers. At a certain age and in younger patients, it's going to be completely different.
So I have a question for everybody, Maurizio, our dissectors, our injectors. Tell me the significance, in your opinion, of the malar ligament. Is it important to inject pre-periosteally under the malar ligament, or is it okay to inject more superiorly into the SUF? Will you get penetration through the orbicularis and actually end up superficially?
Well, I tend to inject more below the malar ligament and actually at the prezygomatic space. That's the area where I aim to inject first. in order to avoid lymphatic obstruction
Yes.
or all of these problems. Because we know if you inject too superficial above this malar ligament, that's when the problems might
So in
happen.
other words, you can inject into the SOOF, as we've been seeing
Yeah.
on this demonstration, and still get penetration through the orbicularis
Yes. Yeah.
into the subcutaneous fat, where you may not want to be.
Benita, please show us the malar ligament, because we are talking about anatomical structures.
Yeah.
No, before, but I want to have the correlation. Is it possible that you show us again the malar ligament, please?
Okay.
So, okay, for
You
those
can
who,
see some
for those who did not get it, the discussion here above or more deeper to malar ligament, this is the area that we are talking about. This is the area in which you can see clinically malar mounds because
Yeah.
of lymphatic dysfunction.
Yeah.
So you have to be very careful when we inject there any filler, especially HA, which absorbs water. Malar mounds can become more severe.
I have a question from Maurizio. Can you see this on ultrasound, the malar ligament?
Oh, sure.
Yeah? Can you
can
maybe
see that.
demonstrate it for us quickly?
If we got
Yeah.
the chance to demonstrate that, why not? So we know that the malar ligament is a structure that divides the
Yeah.
supraorbicularis oculi fat in one superior and one inferior part, just below the orbicularis oculi muscle. And I'm going to show you the following thing. Orbicularis oculi muscle is a very thick muscle. I'm going to stop the image right now and go back in time. You have here the bone, you have here the deep fat of the prezygomatic space. This hypoechoic band-like structure is the orbicularis oculi muscle. And have a look at how thick her subcutaneous tissue is in her case, right? So the SOOF is this fatty layer below, right below the orbicularis oculi muscle. This might be that ligament, and below that is the deeper area of the suborbicularis oculi fat. I
So
know this
for
looks a
those
little
who are-
bit difficult, but when you do this all the time, you start to see more things.
So
yeah?
for new ultrasound users, the trick might be just to be immediately pre-periosteal.
Pre-periosteal. I prefer to be pre-periosteal and use something that is
So
more...
it's a sort of an advanced issue, but it's not, because everybody's injecting in this area. So really, it's sort of advanced, but it isn't. Everybody should know it.
Yes.
Yeah. Thank you very much. I think that due to the time restraints, we need to move to the nasal injections. Maybe the last chance just to see the patient. Can we see the mid-face patient final outcomes? Oh, okay, we move to the nose. Okay. Okay, sorry. Okay, we start with nose injection, please.
Nose, can
No.
please zoom in? So I already make a mapping of the vascular to avoid. So like that, the anatomist mentioned before about we all have the vascular all layer, but just lateral to the from the midline around there 3 to 4 millimeter. So we're focusing on the injection just only for the midline area, and we can palpate about the area that between the bone and also the cartilage. So need to be careful about the gap here, because if you inject by the needle, maybe you can rupture in it and you're gonna be push something inside to the nose. And I mark here that is for the needle injection. Actually, needle injection is not 100% safe. You need to be careful to do the aspiration effectively, and I'm going to be show you it's around 10 to 13 seconds. But for the tip of the nose and the lower part of the nose, this is remind me that this area has a plexus of the vascular area. So in this area, I prefer to use the cannula and the big cannula like 22G cannula. And for the nasal spine, I'm going to be inject by the needle injection deep down to the bone, and it's going to be safe. So I'm going to be starting. So the product of choice is large marigoon and highest G palm. Like in my globe here, you can see can you a little bit zoom in here? I'm not sure. Oh, we can see it, so sorry. So it needs to shape the nose, that's why we need the highest G prime and the large marigoon. So I'm gonna start now. So for the first injection, at the higher position, the dorsum of the nose here. Okay, I clean it and deep down to the bone here. So I feel the bone, and after that, I'm very stable position. Oh, you see this one? The blood
I think that
here.
this is the best
So that's
example why
we
you
didn't
don't
know.
need to aspirate. You see, it takes you 10 seconds, and
Yeah, you
then
see?
you understand what you are
Just,
saved from. Okay.
just only a few seconds.
This,
So
is,
actually,
this
this
was an
point
excellent
is safe, but not
example
in
why
everyone.
to those people who actually resist or
Yeah,
do not agree with
aspiration.
aspiration test.
But that looks like a little bit of
Okay.
Venus, right?
It's
Can you
Venus,
please
yeah.
check that syringe?
But
the
it could be
needle?
also arterial.
So actually I don't want to show this, but accidentally, so anytime, so we didn't know. Actually, I did the center. You see, the center, the midline, but it also can be like this. So need to be careful. So again, I just a little bit go down from that point and re-inject it again here and feel the bony structure. And after that, I aspiration. So no need to hurry up. So this one is 10 seconds. It's going to be safe. And a little bit injection, 0.1 cc, and use your finger to guarding. Here is the
So now every the
0.1
demonstration,
here.
every doctor know we should keep 10 seconds. It's very important, yeah.
Yes, no need to be hurry for this area. And after that, it's just molding, and you're going to be see a little bit higher of the nose area now here. In front of, you can see a little bit higher. Okay, the second point here, below it, and again, need to be careful. So here is the second point here, deep down to the bone again, and slowly aspiration here. So I will count in my mind around 10 seconds. Here, stable, and after that, guarding the lateral side and inject slowly. 0.1, in this area, I will inject 0.2 here, because the hole is deeper than the upper part of the dorsum here. So here, and after that, just a little bit molding. And I will be sharing to the cannula to inject the lower part of the nose and the tip too. So the entry point of the injection, so some doctor use a super tip, but I just a little bit downward because I want to go to the deepest parts of the structure, so supraperiosteum and supracondium. So here, just a little, at the center again. So I already did a local anesthesia for injection point here. I use a 22G cannula, so please take off here. Okay, and after that I go deeper, and I use my finger to do the pinch and deep pinch, and I touch to the bone now. So here, even the cannula, you need to aspirate. So be careful every time. And after that, you just block the lateral and inject by slowly a retrograde bolus or retrograde linear injection.
Excuse me, where is your end of your tip, needle tip?
So here is the end of the needle at the middle.
Okay,
if you go deeper, you cannot see it here, but from the length is here. And I inject slowly here.
And here I provide a special issue because in Asia, a lot of people have nasal allergy, and they do the septal nasoplasty to correct the deviated nasal septum. So they remove the nasal septum, makes the patient have a saddle nose. And the saddle nose means the upper lateral cartilage will collapse, and separated from the nasal bone. A lot of people come to the clinic to correct the saddle nose by feeder. So when you do the cannula from the nasal tip, be careful. The end of the needle tip sometimes will penetrate the ligament between the nasal bone and the epididymal cartilage. This means the end of the needle tip will penetrate under the nasal bone into the nasal cavity. And under the nasal bone here is a very important artery. It means the entry ethmoid artery. And in Taiwan, some patients, they do the feeder injection to correct the saddle nose, and the blindness happen. By MRI image finding, they find some feeder under the nasal bone, which means inside the nasal cavity, and the feeder go into the anterior artery. Anterior artery connect with the ophthalmic artery. So it's very important. So if you want to inject the nose, you should ask a patient, do you have ever do any surgery about the nasal septum?
So now I finish the dorsum and also the tip, and I will show the result. I think that after we make a higher dorsum of the nose in this case, it's more attractive look for her. Okay, นั่งตรงนิดนึงครับ. So here, you see?
Yeah, it's a very nice result.
The immediate result after. Yeah, and for the quarter view here, straight the dorsum of the nose and increasing the nasolabial angle. So here, and from the lateral, it's like that.
Yeah, it's
So
actually
the
very
previous
nice.
injection.
It's actually a very nice demonstration why, in spite of all the dangers in nose injecting, the outcomes are sometimes really amazing.
So I hope that next time, next year, I didn't inject for the nose demonstration. Yeah, it's something like that it can be occur, but you need to be careful every time. Slowly, effective aspiration.
Yep.
So,
Okay,
so one quick,
this is my
we might go to our ultrasound,
Thank you very much.
Maurizio.
Yeah.
A quick comment on the nose. I noticed you were
Yes.
mapping it.
I just would love to demonstrate to you something that I
We've
found
got
in
1
this
minute,
patient, because when we inject at the level of the nasofrontal angle, you will find actually pretty much frequent that intercanthal vein, which can be very prominent and thick. That might have a very weak wall, but when you go with your bevel down, you might push it, and then the moment you make the aspiration, that's when you know, or we know that it was actually venous. That's coming from the area of the intercanthal vein. That's exactly on that area. When I inject the noses, I mark there, and I avoid injecting there. And if you have a proper vascular mapping, I like to put my probe horizontally. I identify the nasal bone, which is this white layer right in the middle. And your Doppler has to have very, very sensitive Dopplers. And you need to use a lot of ultrasound gel, because the nose is, at this point, how I am injecting, very curved. So it's a little difficult to pronounce. These little 2 points below are the cartilages, so I go a little bit back and have a look at where might be vessels present. And the moment I do a vertical and horizontal vascular mapping of the nose, then I am more reassured that there you see on your right a very, very weak pulsating. There you go. You have here some vessels. As you can see, there you go. If your midline is free of vessels, then you can give it a go and have more an idea of the anatomy of your patient. There you go. You see on your left side of the image, you see a pulsating. That's at that point the dorsal nasal artery. There you go. You see it there,
Beautiful.
right?
Thank you very much, Maurizio. That's a great demonstration.
Good.
So today we have a beautiful demonstration of dissection, injection, ultrasound. Thank you, everybody.
And complication
And
prevention.
complication
Complication prevention.
So I think, I hope you all enjoyed it because it was a very productive session, I think, for injecting and the dangers. Thank you.
Thank you very much.
Thank you,
Thank
everybody.
you.
Yeah.